Consultation models are really important. These help us to have an effective communication and consultation with our patient. If we don't have a good consultation framework, then we might end up having very dysfunctional consultation. It's not really good for the patient. So the first consultation model we're going to talk about is Neighbour. It was introduced in the inner consultation. So it is a 5-stage process. The first one is about connecting. Second one is summarizing, handing over, safety netting, and housekeeping. So let's start with connecting. What you want to do is to connect with your patient early on, from the start of the consultation, because the trust that you build with your patient and the rapport that you have is going to help you to manage the problem and be able to provide a good care for your patient. But if you don't have a good connection, then it's going to be more difficult for you to do this task. Ask yourself, have you got rapport with your patient? Building rapport is something that you do from the beginning. So it starts with a smile. You know, even when you're talking over the phone, when you're speaking with a smile, when you introduce yourself, when you greet the patient can sense when somebody is enthusiastic and friendly, and this will build the rapport from the get-go. There's also gambits and curtain raisers depending on what sort of question you ask in the opening, so that you get the patient to tell the story, to encourage the patient to tell you the story and connect with that. Also, when you're connecting, it's important that you pay attention, as in what are the cues that the patient might be leaving for you, and also what are they saying and what they are not saying as well. There are things that they might not be saying, and pick up on anything that you find they might not be saying as well. So the second stage is summarizing. Have you sufficiently understood why the patient has come to see you? So this is where, when you ask this question, it will help you to understand whether you've got enough information to understand what's going on here. What you want to do is to elicit various components in the patient's history. So for example, you want to check what are they feeling, what are the ideas, concern, expectation, what are the effects of the symptoms, the treatment, what's going on in the patient's mind, what's happening, what's the story, and what are the problems that they might come with when they book that consultation. So when you ask yourself what's the reason this patient is coming, and you understand the story, then you can actually move to the next part of the consultation. So the next part is handing over. When it comes to handing over, what you want to ask yourself is, has the patient accepted the management plan we have agreed? Because so often what happens is that the management plan is agreed only partially with the patient, and the patient is not fully involved in there. And it's important that you think about how you can influence the patient in involving them in the management, and also negotiate with the patient. There's also this concept called gift wrapping in the inner consultation. So gift wrapping is about, when you're giving a person a gift, you want to wrap that present and then give it to that person. Similarly, when you're making a plan for your patient, you can gift wrap that management plan. So for example, if a patient presents with migraine and they're having a lot of problem with this headache and vomiting, you can link back what the patient expressed in the data gathering. For example, they've had some vomiting. You can say to the patient, I understand you've been having vomiting with this headache. And part of the treatment also involve having something like an anti-sickness. Is this something that you'd like to help you with the sickness you've been having? So you see how you package the management to tailor it to the patient. So you can gift wrap that management plan so that it's tailored to that patient, instead of just saying the patient the management of migraine is this and that, and you're not really having this gift wrapping process before you make the plan. So when you're doing that, then the patient will feel that they've been listened, because you brought things that they've said to you before and you've understood them. And it will help in the management plan, because they'll also be involved when you're asking them that question, whether they'd like to have something. The next part is safety netting. Safety netting is very important because we're dealing with a lot of uncertainty in general practice. So general practice is the art of managing uncertainty. And this is why safety netting is really crucial. But the way that is done is also important. So often people safety net in very vague way and it's very weak. For example, saying to a patient, if it's getting worse, give us a ring back. If it's not improving, give us a ring back. You see, this safety netting is not bad, but it's very unspecific. What you want to do is to show the patient exactly what are the signs or symptoms that they need to look out for. Also let them know what to expect. For example, if you start a patient on a course of amoxicillin, let the patient know that I'm expecting this antibiotic to work over the next 2 days. You might see an improvement if it's working. However, if you don't find any improvement, then please give us a ring back because we might need to consider a different antibiotic. Or you can say to the patient, if you do develop any fever, worsening of your headache, if you start having any vomiting or rash, please give us a ring back on the phone number that for the surgery, for example. Or if it's out of hours, please call 111. You see, when you have got this specific plan in place, the safety net is more robust and the patient is aware what they need to look out for. So think about what are your contingency plans if you're not right in the diagnosis, because we can't be 100% certain that our diagnosis is right. So we need to have contingency plans if, for example, we're wrong or if the things that we've diagnosed might worsen and there might be complications, so that the patient know what to do next. So that's why when you're safety netting, think about from a patient perspective, what do they need to look out for and what they have to do next. Then there's housekeeping. So housekeeping is recognizing that the doctor needs to have some level of good shape in their condition to be able to see the next patient. So it's important before you see your next patient, ask yourself, am I in good enough shape for the next patient? Because if, for example, the last patient you've seen has been very challenging and you still have got some things that in your mind, then it's going to be difficult for you to start the next consultation, especially for some of you who are going to see the SEA. If you're having 3 minutes break and then you're going to see the next patient, you need to be able to forget the last one and then focus on the next one. So take a deep breath in and out and make sure that you try and help yourself to be in a state to be ready to see the next patient. If it's in your surgery, you can actually go for make a cup of tea, for example, and then come back. But for the exam, it's different. You won't have time to do that. So it's important that you're aware about that. So be aware of yourself, whether you're feeling stressed, whether you're finding it difficult to concentrate, or if you're lacking any equanimity, then you need to have a way of channeling your energy so that you're ready to see the next patient. So Neighbour's consultation model is quite simple and it's quite useful as well. So it's very easy to remember. So you can use your hand to remember each component of the consultation model. The next consultation model is Calgary Cambridge Guide. This is a very popular one and it's focused on various tasks that the doctor needs to do. So initiating a session, gathering information, physical examination, explanation and planning, and then closing the session. There's also two processes along the way. So providing structure and building relationship. So beginning with initiating the session, so it all comes down to preparation. You know, when you start the consultation, you can't just go blindly. You have to prepare the consultation beforehand. So have a look at the case record, check anything that's relevant, any last letter, check the medication that the patient is on. Could there be anything that might be relevant with the treatment that you might need to discuss? And think about anything that might come out in the consultation and feel free to write down and make a note of it such that when you're consulting, you don't overlook things that might be obvious. So then it's about establishing rapport initially. It's really important that you make a good first impression, because if you have got a good first impression, the consultation is more likely to flow well. However, if you start on the wrong foot, it's going to be very difficult for you to make a better impression later. So that's why you want to start strong and set the tone for the rest of the consultation. And again, you want to identify the reason for the consultation. You want to know what's the reason the patient booked this appointment, or what's this consultation about. The next stage is gathering information. So data gathering is exploring the patient's problem so that you can discover the biomedical perspective, the patient's perspective, and also the background information, the context of the patient's presentation. When you have got the context, you've got the nub of the case. So often what happens is that most doctors, they focus so much on the biomedical, and then the background is something that they do afterwards without really being aware of the implications. So what you want to do is to consider the patient in a holistic view. So not just think about the disease model, but also think about the patient's perspective and the social context, because the patient is also a human being living in a community. They might be working, they might have family and friends, and then there are other things that's going on in their life. So that could have an implication on the treatment that you recommend. So when you're thinking about the psychosocial model, which is something that Calgary Cambridge does very well, then you will get a better picture of what's going on in the patient's presentation. After you've gathered the information, then the next step would be physical examination. Then the next step after that would be explanation and planning. So you've identified the problem and you've got an idea what's going on. Then the next part is how you're going to solve that problem, how you're going to plan and explain to the patient what's going on. So you want to make sure that you're providing the correct amount and type of information for your patient. So every patient is different. So some patients might want to know more, other patients don't really want to know much. It depends really on the patient that you're consulting. And you have to tailor that to the patient you've got in front of you, or on the other end of the line, or on the other side of the screen. So you could actually check how much the patient might want to know, or whether they already know about the subject before you offer an explanation about something. Link back again the language using the similar language that the patient has expressed their problem, and to get on the same page as your patient, so that you've got a good understanding. So when you have a good understanding of the problem, and you also get the patient on the same page as you, then you can share the management. So for example, if a patient is worried that the back pain might be due to an infection, but you think that this back pain is because of arthritis, for example, then it's very difficult for you then to have a shared management if you don't have shared understanding. So that's why it's important to make sure that you readdress the patient's idea and explain why you think this is arthritis instead of an infection. Then you will find that it's easier for you to develop a shared management with your patient. But if you miss that step of shared understanding, it's very difficult to get shared management with your patient. So then what you want to do is that you incorporate the patient's contribution to the story and explain what's going on, and then discuss some management that you recommend for them. So planning the shared decision making, so involving your patient in that. And after you've done that, what you want to do is that you're ensuring that there's appropriate point of closure. So, sometimes with telephone consultation, what happens is that you might end the consultation abruptly, or for video consultation. You want to make sure that the patient understands what's going to happen next as well. So let the patient know It was nice to speak to you, Mr. Smith. Thank you for telling me about this problem you've got with your back. This is what we've agreed today, and I'm going to send a script to your chemist so you can collect the medication today, and I plan to arrange a follow-up in 2 weeks' time to see how you're getting on. So you see, you have proper closure, and also if you need to arrange a follow-up plan as well, then you do that. So then when you close the session, the patient understands what's going to happen next. While you're doing these tasks, from initiating the session to gathering information, explanation, and planning, there's also a need to make sure that you've got a good flow in the consultation. So providing a structure, because what you don't want is to have a very transactional interaction with your patient. You want to be able to flow the consultation and be able to have a good rapport with your patient as you're talking and making your plan. So making sure that you're attending to the flow, being present and listening to your patient, and also you want to develop that rapport as you go along in the consultation. So it's not just in the beginning to connect with your patient, but you want to build rapport during the consultation as well. So we'll talk about how you build rapport with your patient in a bit. But before we do that, let's talk about this last model, which is Berne's model. So Berne's model is about the ego state that we've got. So according to Berne's, there are 3 ego states that exist. There's a child, the parent, and the adult. So in a consultation, you might be adopting one of these ego states. So what usually happens is that you've got the parent who could be a nurturing parent or critical parent. So there's a critical parent and there's nurturing parent. Then you've got the adult. The adult is a logical person. So when you're dealing with an adult ego state, what happens is that it's easier for you to have a dialogue with an adult ego state. And then you've got a child ego state. So for the child ego state, this is where it's more difficult for you to resonate with that ego state. In most of the dysfunctional consultation, what you might find in the dynamic of the consultation is a parent to child ego state. The doctor is the ego state of a parent, and the patient takes the ego state of a child. And this is where you might find that the consultation don't go very well, because you might be too doctor-centered, as if you're making a decision for a child, you will tell them what to do. And it's more difficult for the patient really to adhere to that treatment plan, because they don't feel that their autonomy is respected. So when you're aware of these 3 different ego states, then it will be helpful for you to make sure that you aim for adult to adult interaction with your patient, so that you don't flip into parent-child, where you're telling the patient what to do, because you want to respect the patient's autonomy. And this will help the patient to manage the problem themselves. For example, when it comes to chronic diseases, part of the management is self-management. So it's important to get the patient to be involved in that decision making, so that they can continue and manage the problem if it's something that they can do on their own. It's important that you're aware what's your consultation style. If you don't know what sort of style you are, then it's helpful to try bits and pieces from each of the different consultation model and see which one works for you. And then you can adapt that to your own style and see which one flow well with you. It's very important that you have a framework, because you can get lost and miss things. So what you want to do is make sure that you give yourself enough time to prep. Ideally, you want to focus on the story in the beginning. So ask open questions, especially if it's a telephone consultation. You don't see any visual cues. You don't know what's going on in the patient's life right now. So you want to know as much as possible. So by asking open question in the beginning, you will get more information. If you try and close it too soon by asking closed question, then you might have to work harder to get more information later. So you want to ask as much open question as you can. Listen actively to what the patient is telling you. And sometimes what happens is that the patient will leave cues and they will say things. There might be things that might not be relevant, but there are things that could be relevant. So it's important to have this intuition, to know which one to uncover and follow up. And this is something that as you see more patients or consult more patients, you will get a better sense as in what are the relevant cues and which one might not be relevant. So then you ask questions to get access to the patient's mindset. So you want to know what's in their mind, what are they worried about, what they're concerned about, what they're feeling about something. And you ask this question. So the way you ask this question is also important. It's not just about just saying something, but how you say it, whether you're asking it in a way that is in context or whether it's sounding very formulaic. For example, if a patient is coming with a knee pain, then they might have got some thoughts about what they will tell you in the beginning. So by asking the question, open question, you'll tell you the story. Then if you want to know more about what's going on, you can tell them, "Oh, what were your thoughts about this knee pain?" So then the patient will tell you. And then you ask another question. For example, if you find the patient was quite worried, you can tell, I sense that you're very worried about this knee problem. Tell me, was anything concerning you? So you see, you link it back to what you have observed and put it in context. Then make sure that you don't forget the red flags, because if you forget these red flags, it's not going to be a safe assessment. Make sure that you have thought about possible red flags that you want to ask. Think about the patient's life, their home life, their occupation, and ask questions about how has his headaches stopped you from doing anything at home, or has it affected anything that you could do? So you see how you're asking it in context instead of just asking how things at home, who lives with you at home, because these are very formulaic questions. You want to ask the questions in a way that is in context. So by using the presenting complaint and link it back to what question you want to ask. When the patient tells you they're concerned about, let's say they've got a ligament problem, make sure you make a note of that, because you want to readdress that afterwards, because this is where you're going to share your understanding with your patient, as in what you think is going on, why you don't think this is a ligament problem, whether you think that's osteoarthritis, for example. Then you can make a shared management. So you need to be able to actually readdress what's going on in the patient's mind before you can discuss and make a plan and reach a plan with your patient. Because if you don't do that, then the patient's still worried about their ligament, for example. And after you've discussed and explained what's going on, then you make a plan with your patient by recommending what they could do treatment-wise, and if there's any need for physio, for example, or if you have to see them again. And you can actually make sure that you're giving the appropriate safety netting advice. So it's important that you write down your structure, write down the framework, how you start, and where you go from after you've started the story, and the red flags, the ice, and also about the management as well, to structure it. Because if you haven't got that structure, then your consultation is not going to be very fluid. So make sure that you adapt your consultation. There will be case scenarios where you might not have to take a lot of history. For example, if you're having to discuss the results with a patient, or if you've got a patient presenting with a request, for example, a vasectomy request, then you'll find that the idea or concern or expectation might come later. For example, after you've explained to the patient about the results and you found out that they've got a relapse of leukemia, for example, then what happens is that then the patient might start to tell you their concern, and you will have to readdress that concern after you've explained and made the diagnosis. Are you struggling with your consultation skills? Maybe you need help and you want to get constructive feedback. If you'd like to get help, then click the link down the description below to see whether I can help you. If I can help you, then we can enroll you on the one-to-one coaching program. Take care, everybody. Bye-bye.